outside, right from the skull base until outside, everything will remain compressed for a few days. See this?
Yes, yes.
I want to compress the inner marrow cell with this outer marrow cell, see till outside. And this will swell up, and what I'm using to swell up all this assembly of the marrow cell is the betadine, the povidone iodine, another third layer of antibiotic. See this?
Satish,
And yes.
I have a question, basic question, because I am an illiterate person.
Oh,
What is the
really?
Mirocell actually?
Hmm.
What it is made of?
Pardon?
Mirocell is made up of what? What is this material?
I think you know it. I know.
No,
I know him.
this absorbs a lot of fluids around and it swells up like more than the gel form, and then it compresses. So it
Yes.
has a many holes and many say
Yeah, that's why marrow cell has a pore, has a lot of pores, you know.
dead space inside, and which swells up with the thick fluid, and because of the thick fluid, and swells up.
Now see my assembly till skull base. Let me enumerate again. The first layer was the fat, the compressed flat layer of the fat on the dural and the surrounding surface. Number one, agreed? That was
Yeah.
fixed with the glue in place, agreed?
Yes.
The fat was soaked in rifampicin, then covered with the glue. Then everything was covered with a vascularized flap and secured in place with the glue. Okay? Then this entire assembly was uniformly covered all around with a gel form soaked in ciprofloxacin to give uniform compression. And until then, it is, not removable until gel form. Now, since we want a compression for 3-4 days of the entire assembly, we use two perpendicular layer of marrow cell. The first half marrow cell vertically onto the entire skull base area onto the gel form. And since this marrow cell need to be removed, we interpose a non-sticky layer of silastic between the gel form and marrow cell. So one horizontal marrow cell, and that is kept in place till anterior of the nose, anterior part of the nose, with a vertical piece of marrow cell. And this entire assembly right from here will be compressed till skull base for 3 to 4 days. After 4 days, we'll remove one by one both the marrow cell and the silastic, and rest will leave above there. And until then, it will be totally compressed. The fibroblastic reaction will take place as the glue will initiate the fibroblastic reaction more, and the entire assembly will stick to the entire raw area. Everything will work. Everything will stick to the area because we created a one side, 1 centimeter all around raw area. And that could be possible only by dissection of all the sinuses. And that time we ensure that all the sinuses, even till closer, till end, we ensure that all the sinuses, dependent sinuses, bigger sinuses, we have ensured their ventilation and drainage. They are not blocked to give secondary sinusitis. That is the entire goal behind this approach. This could have been done much earlier, like sealing a puncture by pushing something in, but that would never work. This requires a more perfect, um, approach, looking at a longer perspective, long duration perspective, to prevent future problem, future leaks, future sinusitis, any other future problem, and more than that, future surveillance. We have used a vascularized flap to prevent future secondary infection, because now this will give a primary healing to the area of interest. So future infection can be prevented with the vascularized flap in place, and this will give us a long-term surveillance. You put a 0 degree in your outpatient department, and you'll find if any problem happening to the patient, or any leak, or anything dislodged, or anything happening to it. You don't need imaging in the future, as everything now is in your, in view. Post-operatively, you just need to put a 0 degree in your office, and you can see everything in place. That is what about our technique of this CSF leak repair for the ventral skull base. Yes, sir.
Sir, you have said that we will remove that Mirocil and we leave the Celastic and the overlay gel form.
No,
It
no,
will
we
not.
will remove the silastic. We will
Celastic
remove both the pieces of marrow cell as well as silastic, both.
both, and leave that overlay gel form piece.
Yes, the gel form will get absorbed, and underneath the gel form are the layers of the fat and the fascia. Until then, that will be taken up.
Fine, sir. Sir, one more question, sir. If
ये लगा दो.
suppose, hello,
अरे वो चालू कर दो कैमरा. हाँ, yes,
are you hearing me, sir?
yes, very well. Yes, please.
Suppose if this is large defect and this is not able to close by the coagulator, in that case, how you will proceed?
Yes. So in larger defects, we insinuate the fat inside and outside, and we plug it like a bath plug. So part of the fat will go intracranial, and part will the fat will come extracranial through the defect, and it will be a tight, pull through closure like a bath plug. And then we'll again the same way we'll put the other, the glue and the flap and other things over it. So that will be a little difference. In this case, there was tiny defect, very small defect, which I was presuming, hoping to be, sealed by the coagulator, as it seals the works on the bipolar principle and seals the arachnoid layers very effectively, and it seals in no time. See, the defect was sealed like anything, and this works like anything. We have done so many. So this is our protocol.
Thank you, sir. That's a beautiful technique. One more question, sir. Last question, please.
Yes, please, please.
One of our colleagues just asked about the Merocil and the silastic tube that you have kept to pack the repair. While removing, when you said that the Merocil you'll remove after 4 days, that can be done in ward. What about the silastic tube that can be removed in the ward? You will use a nasal speculum, or you'll just pull it through?
After 3 to 4 days, we remove everything under endoscopic guidance.
Okay.
We will remove the first layer of Merocil, we'll remove the second layer of Merocil, and then we'll remove the silastic, and we will pour some topical antibiotic all over and come out, and then we start the saline nasal sprays to keep the area moist, to prevent the crusting, and to promote the healing.
Satish boss, one thing that is very important regarding the repair of the smaller as well as the larger ones, the defects.
Yes.
When you encounter the larger one defects,
Yes.
in case, have you in your experience, you have a experience of going into placing a lumbar drain as well as doing the surgery, or doing a lumbar drain post surgery, and it has influenced the final outcome of many of the patients?
Yes, that's a very important question. Very valid question. Let me give you our indications for lumbar drain. Lumbar drain we use for the larger defects, obviously. And now in this era of endoscopy skull surgery, rather we create bigger defects. In the transplanum approach, in craniopharyngiomas and other supracellular lesions, we create so many bigger defects. We create defects in centimeters sometimes and seal in multiple layers. So our indications for lumbar drains are for larger defect, that too in the vicinity of a bigger cistern, like supracellular or like transclival. All the defects we always use a lumbar drain. Then we use a lumbar drain for revision surgeries, because you can't take a chance. Lumbar drain will divert the pressure and will ensure that your seal is not disturbed for a couple of days until the fibroblastic reaction takes place. So for all revision leaks, we, on the preventive basis, to stay on a safer side, we use a lumbar drain. Third, in post-radiation sequences, post-radiation situations, like tumors, we resect sometimes the benign malignant tumors, radiated, and there is a leak. Some tumor partly that was removed and some leak is there. We always use a lumbar drain, because in post-radiation situation, the healing is expected to be poor, and we don't want a high pressure along with. So, and the fourth is, in extremely high pressure situations, we always use a lumbar drain. For time being, monitor it. If the pressure remains persistently elevated, then you have to take a call of diversion and other things. That is our protocol. So lumbar drain is not for all defects. Like for this defect, we'll never use lumbar drain. It doesn't fall into any of the category I described for the indications of lumbar drain. I hope it is clear.
Yeah, it's very clear to everyone. Have you recorded this all the surgery?
Yes, anybody can watch on YouTube always.
Can you send the link in the group so we can share it with those who were there in the dissection hall, almost half of the people.
I
So they-
will share in the group straight away.
Yeah.
Anything
You
more,
mostly deal with
any
the nose and paranasal sinuses. So what is your choice for per-op and post-op antibiotics in these cases?
see, mostly the topical antibiotic works. Like we have used rifampicin, we have used ciprofloxacin, and we have used betadine for 4 days. In the entire cavities, I mean, furnished with betadine all around. And yes, you have to give a broad spectrum antibiotic to prevent any secondary infections in the nasal cavity. Nasal cavity has its own inhabitants, bacteria as well. So those are not virulent, but still you can't take a chance. But with this kind of a closure and this kind of the sealing with a vascularized flap, the biggest way of preventing post-operative infection at the skull base level. Infection in the cavity is different. At the skull base level, at the level where we seal the skull base, the biggest factor in preventing infection is the vascularized flap. This case could have been done without a flap. It was a small leak. The flap was not actually meant to seal the leak. It was meant to give a primary healing. Try to understand.
Okay, sir.
Same thing can be used for various regions, and here the flap was used to promote the primary healing, to prevent the fat getting necrose. This is the reason behind using the flap over there, because the septum raw area which we have left behind can heal secondarily. We will use saline sprays to prevent, crusting, moisturize. We can do debridement of the crust later on periodically, and this septum area heals within couple of weeks without giving any problem. You can't afford to take that risk of secondary infection and healing issues at the level of the skull base.
Sir, have you ever experienced osteomyelitis of skull base?
Not really with this technique, never. But yes, if you leave raw areas without vascularized flap, with avascular bone, if it is in an immunocompromised patient, it can happen, and that is troublesome, always troublesome to treat. Whenever
Yes, sir.
osteomyelitis, then you have to treat it like any other osteomyelitis, debride it, and
Revision surgery or is already irradiated in these patients, they can happen.
yes. Any other questions? Anything related to CSF leak, please.
Sir, one more thing that is very important is that during the surgery for the cellular or supracellular tumors, if you encounter a arachnoid leak and the CSF is there,
There
then
is
according
always,
as you
create a
see,
leak.
yeah, there is a leak while doing a pituitary surgery, the cellular or supracellular, what kind
Pituitary
of
is different. You're talking about the supracellular.
I am apart from this, apart from the discussion that is going in this case, sir,
Yeah.
I am asking the final question regarding the things that we routinely encounter, sir. That during
Yeah.
doing a surgery for pituitary tumor, either cellular or supracellular, and we have a arachnoid leak. The
Yes.
CSF leak is there, but the leak is smaller one, not a
Yes.
bigger one.
Yes.
And you people or even neurosurgeons, they generally proceed the way by going through a head-art flap and covering the whole defect over there and placing the
Yes.
glue and other things, fat and fascia. So is
Yes.
it really required when the small CSF leak is there while doing a routine pituitary surgery, that going one way, doing the repair with the fat and fascia and applying the glue, and other one is applying other things and applying the head-art flap? So what do you think in your experience is the really way in which we should proceed?
See, it all depends on how much of the tumor you have removed. See, if you remove the tumor completely and you have a small leak there, you can afford the complete, obliteration of the cella with the fat and a head flap over there to prevent future problems. But for a small leak, in those situations, if you don't want to obliterate, you have an option of sealing with the fat and glue and all that, and then put a lumbar drain for a few days to divert and allow the seal to be taken up. So the both the ways in iatrogenic leaks. Iatrogenic leaks tend to heal. They have fresh margins. They tend to heal better than these persistent leaks. That is altogether a different situation. For iatrogenic leaks, you seal with the fat and glue and divert the pressure from that area for allow the fat to be taken up. It can work like anything because they have fresh margins. They tend to heal spontaneously unless some pressure is preventing. So iatrogenic leak is a different situation. That is the simplest situation I would say to deal with.
So is there any question? Otherwise, we'll call it.
We can take any questions, no problem.
There is one more.
Sir, this is compliment from us. You are like a magician. The way you work and describe, it's wonderful, sir.
Thank you all.
Mike
Thank you all. This is a part
Mike
of academics that we benefit each other, and I am really grateful to Dr. K.K. Bansal and the entire team Narayana for me giving me this opportunity to demonstrate from our own hospital, Jain ENT Hospital here. And thank you once again. If you want to see more different variety in complicated CSF league repairs, you can go to YouTube, type my name and CSF league, and you'll get variety of unedited videos with full commentary on it. So many CSF leagues we have on YouTube for propagation of our technique for the benefit of everybody. You can see there.
Excellent demonstration, and I mean, such a beautiful repair. The only thing,
Yadram sir, we have always been learning from you for years together. You are the,
thank
you
you.
know, you're the legend in this field, and people are looking up to learn from you every day. And we have learned personally from you so many times. Thank you so much for being with us today.
Thank you very much. Excellent.
Satish, we are closing this session here, and we are starting lunch now. And then you have to come back immediately from there, because you are a teacher on one of the table. So where the participants will dissect the cadaver. So you have to teach them here also. And so you have to start now only. We'll start lunch by the time you reach. So the Mirocell you told me, I asked you. So the Mirocell is actually a hydroxylated polyvinyl acetate. It's a chemical compound which is a porous structure, and when you put it anywhere, it absorbs the mucosa, blood, and whatever the secretions are there, and it swells up and it closes the dead space. So that's what our purpose is, that whatever we have put and fixed there should stay there for 3-4 days till the healing occurs. Right? Am I wrong, Satish?
Yes, absolutely fine. Now, substitute of Mirocell. There are certain substitutes which are absorbable. You don't need to remove them. Removal of Mirocell is another big trauma to the patient. Sometimes it gives pain, it is a fear of doing another procedure. Pack removal is a procedure, I would say. So the other absorbable options are Marogel. Marogel is the same thing which is absorbable. Another thing is a nasopore, again, which is absorbable. So in situations where you can't afford to remove the pack for reasons for uncooperative patients, long distance patients, you can use the absorbable options like nasopore and Marozol, which can serve the same purpose of the what we are using for, and you don't need to remove the pack at all.
I would request Dr. Ramesh to give you a thank.
Again, it was excellent demonstration, extensive video showing the complete anatomy and identifying the defect and closing the defect. It's really a 3D movie kind of thing. We watched and enjoyed that. On behalf of all the students and faculty sitting here, it's a big cheers to you, and it's an excellent presentation.
Thank you so much once again. Thank you.
So let's go for lunch now to third floor here, and then after that lunch we'll go again to